Good afternoon, ladies and gentlemen. Yes, we've been talking about leadership, but if you want to test the quality of the leader, give that leader money. And you see how he manages it. Then you'll know that that leader is good or not. So I'm Peter Asiimwe from Enabel. Enabel is formerly Belgian Technical Corporation. It is the Belgian Development Agency that implements bilateral cooperation between government of Belgium and the government of Uganda. So we run projects in Rwenzori region and West Nile region, covering now 17 districts. And we've been piloting this kind of mechanism of financing called result-based financing. In Uganda, the song has always been, we don't have money. You go to a health facility, why don't you have a microscope? We don't have money. Why are you not employing the right staff? We don't have money. Okay? But we also know that we've been government donors, development partners, everybody, patients, have been putting money into the system. But how that money is, earned and spent and utilized is a challenge, partly because of previously what we used to call input-based financing, which still goes on. So the Belgian government, together with the Ministry of Health, because we implement these projects together with the Ministry of Health, and that's where we are best, we said, let's take it the other way around. You do the work, the facility does the work, and we pay you according to the work that you do. Okay? And we are finding that actually, health facilities that have very good leaders earn more money. Health facilities that have poor leaders earn zero money, And that's the biggest lesson I want to bring here. So briefly, I will go through RBF, the way it operates, and then I'll try to answer the question whether RBF really has a link with leadership capacity building, and just a few lessons learned. Next. So when we talk about result-based financing, it's mainly a financing mechanism of health facilities. You stop sending money, sending equipment, sending staff to a health facility, but instead say, this facility, please work, and then we pay you for the results that you have actually performed. Who is controlling the... Next. Okay. So one of the things we've done is to ensure that we have a national policy framework that supports result-based financing. And overall, the government of Uganda feels that in order to enhance utilization and efficiency and quality of health services in the country, you will need to ensure that you adopt this approach of financing. Okay? And also, it is very good in putting resources to ensure that they are adequate. And our ultimate goal is to move towards the National Health Insurance Scheme. Okay, so RBF in the health system strengthening perspective should not be seen as an objective, but rather it's just a means of making sure that you are able to have adequate financing for your health system. So it's a fund allocation mechanism, and it's not a magic bullet that can solve all the challenges. Briefly, this is what we do. Before we take on a health facility, and we have around 80 facilities that we are working in, there is a process for pre-qualification. And this is where we found that actually most health facilities that had issues with leadership and management could not qualify to go to be supported under this project. So in the pre-qualification phase, we are looking at basic requirements of infrastructure, equipment, human resources, and the software, things like, do you have a governance board? Do you have, the financial management procedures and all that? Then every quarter, we do a quality check. We do a check on the quality of services that you provide. And we incentivize that. We pay. We give you real money for that. And at the same time, we assess the outputs, the patients that you have treated. And for each patient, we attach a price, and we calculate the number of patients you treated, and you have an invoice, and we pay for that. So 3 major issues that I wish to bring out. 1, the emphasis is on quality of care. Otherwise, in Uganda, we knew that if we said that we shall pay you by the number of patients you treat, we would have a disaster. Yeah, because a clinical officer would sit in his clinical room and simply say, next, and at the end of the day, you have a long bill of so many patients who are just treated. So we emphasize on quality, basics, so that, for instance, each patient must be seen by a qualified medical personnel. Each patient must go away with drugs if prescribed. If the prescription is made but there is no medicine dispensed, we don't pay for that patient. Those kinds of things. In other words, a patient to be paid for must be seen according to the clinical guidelines. The second aspect, which has really tested the leadership potential of health facility in charges and managers, is the second one. RBF works on the autonomy. There is autonomy of the health facility to decide on how to spend the money they have earned. Okay? In one health facility, we paid, the in-charge went, withdrew the money, put it in the pocket, and disappeared. We don't know whether that was the way they decided that is how, as a facility, that's how we should spend the money. Okay? But the other thing that we focus on is that there should be proper planning. So we introduced the concept of business planning in every health facility, upon which we allow for the expenses of this money. And then we work a lot with the districts. I've seen several DHOs here who are in this, especially from the Rwenzori region. Previously, the district was not so much into the life and functioning, especially of the PNFP health facilities. Now with this, because they are the ones that verify, they are the ones that supervise, we see a lot of support from the districts. And we would say that the leadership potential of the DHTs has also improved with RBF. And by the way, we also pay, the districts are also paid based on RBF. So they also perform, and then we pay. Yes, now looking at leadership capacity, does RBF contribute to leadership capacity? It depends on the design. If your design of the RBF scheme is that you only focus on outputs, the leadership may not be so much built, because outputs are easy to work by, especially in Uganda where the population, the disease burden is high. But when you have an inbuilt indicators targeting quality, and in this case we targeted also quality of leadership and management. And so every quarter we assess the capacity of the facility, facilities governance profile. Do you have management meetings? Do you keep records? Do you have segregation of functions, etc.? We also put emphasis on promotion of partnership with the community. Quite often the health facilities were seeing the community as, I don't know, but we want to see that the community that is served by the health facility is engaged. And that's a good sign of leadership. And then, of course, management of logistics and supplies, management of HR, and management of finance. And most importantly, the working environment. When you now move into the health facilities where we are in Western Uganda, you'll find that the working environment, the cleanliness, the general appearance of the place has really greatly improved because these things are assessed. And sometimes, I think in Uganda, we lack a culture of maintenance. Buildings dilapidated, you know, the paint that the colonialist left is still what is there 50 years ago. So all these things, we are trying to ensure that the working environment improves. And finally, the facility has to have an inbuilt mechanism for monitoring and evaluation. Okay, so a few improvements we see, especially for PNFPs, they have now realized that for you to serve your community better, you must remove the barriers because our ultimate objective is universal health coverage. So if as a leader you are not able to see that the people you serve, this is what is barring them from accessing care, then that's bad. So the PNFPs have really moved a lot towards that, flattening their fees, reducing fees. In Western Nile, we see complete removal of fees, and now the facilities are highly utilized. Then the concept of business and strategic planning. We have a posters Enabel on this, and my colleague will be there to show you our approach. But for a very long time, health facilities, especially health center threes, did not look at long-term planning. Even hospitals, you survive per day. Do I have drugs? Is the clinic office around? That day ends. Then tomorrow you again, at the end of the month, you are struggling to look for salaries for PNFPs. So we are trying to inculcate a culture of long-term planning because leadership without a vision is dangerous. And then, of course, we've improved financial management, availability of medicines, and then a key component of staff bonuses. 25% of the money that the facility earns is given to staff as bonuses. Now, how they share that money is where leadership again is tested. Issues of teamwork. We've seen cases where the medical superintendent wants to take 60% of the bonuses, and then the other staff less. And that also affects this. And then the functionality of boards has also greatly improved. Finally, as I said, RBF is not a magic bullet. There are some, the bad side, the bad issues of RBF, and they pose ethical challenges for leaders. Neglected services that are not rewarded. Because you are not paying, maybe paying me for a cesarean section. For instance, we don't pay for scissors. We count it as a delivery, as an institutional delivery. Because we didn't want to, we wanted to avoid cases where every mother is cut because there is an amount of money attached to it. So some of these things are neglected because they are not rewarded. Other facilities may tend to go for services that have a less cost to deliver, and then neglect the others. Some facilities now go to start giving bar of soap, for every mother that delivers or comes for antenatal care. Because we pay 40,000 for a delivery, and that's a lot of money for a health center 3. So when you want to attract the mother to come back to deliver, you give something, you'd call it a bribe or something like that. And a number of others. You have falsification of data because you want to earn more money. So all these are ethical challenges that really pose a great challenge. And I think the last slide, yeah, these are just lessons learned. We see that there is increased institutional self-monitoring, which is very good. Facility staff are motivated to work as a team because the team performance results into incentives for everybody. So the more money you make, the more money that goes into your pocket as a staff. And that has a lot of effect on that. Thank you so much.